During this in-service, we will review the pediatric pain team and the modalities they provide for pain management, focusing on the management of the patient with an epidural. The pediatric pain service team also provides services such as peripheral nerve blocks, PCA management, and low-dose ketamine. For more information on these, please refer to your e-learning assignment or policy stat. We will now review epidurals and the specifics for pediatric patients at SMCS. Epidural infusions are administered through the Sapphire epidural pump. In addition to the unit standard of assessments and vital signs, frequent assessments are required. Please refer to the provider orders for details. Epidurals can be programmed in various modes. These include continuous infusion, continuous with an RN or clinician bolus, or patient-controlled epidural analgesia or PCEA mode. It is vital that you perform these steps during any handoff in care. Please note the marking depicted here. A cluster of 3 dots together equals 15 millimeters. A cluster of 4 dots together equals 20 millimeters, and so on. It is also vital that you assess a patient's sensation. Ask the patient if they have any areas of numbness or tingling. Assess for areas of abnormal sensation on both the right and left side of the body. Numbness, tingling, and abnormal sensation can be expected. Your goal is to determine if the sensory findings are changing, in particular, whether the sensory level is rising. Additionally, you must assess the patient's motor function. Assess whether the patient can lift their knees and legs off the bed. If the patient has a thoracic level catheter, also assess whether the patient can lift their hips off the bed. Motor function should remain intact with an epidural catheter, and the patient should be able to perform these functions. Additional assessments for the patient with an epidural catheter include: for a patient receiving a local anesthetic, evaluate for circumoral numbness or tingling, metallic taste, and/or tinnitus. These can be early signs of local anesthetic toxicity and should be reported to the anesthesiologist. Assess the dressing site. It should be intact, not leaking, and free of redness or tenderness. The nurse should not remove or replace an epidural dressing. The nurse can reinforce and add tape to the dressing and then should notify the anesthesiologist. Patients may complain of itching or nausea, and they may have urinary retention. See provider orders for how to manage these side effects. Notify the anesthesiologist immediately for hypotension or respiratory depression, rapidly increasing sensory level, possibly indicating the epidural is decreasing in effectiveness, rapid onset of motor blockade, meaning loss of motor function, decreased LOC, seizures, or acute mental status changes. Again, if you need additional information on epidurals, please refer to e-learning, policy stat, or Teams. You will now practice programming the Sapphire pump for an epidural.